right, guys, welcome to week 13. This week we are going to be talking about end of life. So, according to Charlotte Eliopoulos back in 2001, she believed that death is inevitable, equivocal, and a universal experience common to all humans. And I completely agree with that. None of us are getting out of this experience alive. At some point in time, our time is going to come and we are no longer going to be on this earth anymore. Everybody's experience with death is probably going to be different. So we're going to talk about what it's like tonight too. We're going to talk about the process of death. We're going to talk about how we help our patients through that. We're going to talk about palliative care, what that means, what it can offer our patients. We're also going to talk about some of the vital signs that we would see as our patients progress towards death. We have a lot to cover. So let's start with this video. See if I can get it to play. And does not want to play. But you guys have this link in the slides yourself, so you guys can click on that after this lecture and go ahead and watch that. So dying is a natural part of the life cycle. We're born, we live our life, and then at the end of our life, whatever time that is, whatever age, dying is the end result of the life that we've lived. Dying is also a part that nurses frequently experience throughout practice, some more than others, depending on what field they work in. A person who works in hospice will deal with death on a regular basis because that is usually the end result with patients that are in hospice. In order for them to meet criteria to go to hospice, they have to have a terminal illness. But no matter what part of nursing you're working in, it is possible that you may have to experience this at some point in your career. So this lecture is going to help provide you with a theory to help enable you, if you ever encounter, a patient that may be terminal, that is experiencing their last days on earth, or if they are actively dying. Hopefully this will enable you to be able to give them the compassionate care that they need at the end of their life. So oftentimes, when we think about dying, when we look at it from the aspect of the medical community, they kind of view that as a failure to successfully cure a disease. We know that as nurses, we do not look at things from a just a medical standpoint. You know that everything we do is from a completely holistic viewpoint. So we do look at that a little bit differently. Death is part of the normal life cycle. Unfortunately, we've talked about that. Our goal as nurses is going to be managing the pain and the symptoms. So when someone is passing away and death is imminent or they're in hospice, we want to make that journey for them pain-free. We want to monitor their symptoms. We want to make sure that they have a very peaceful death. So these are some of the things that nurses will facilitate for these patients. How do we do that? We do that through a very caring community, a team that is sensitive to the patient's needs, their desires, and also their family's needs. Because we know, unfortunately, some patients don't have family or friends, and they do pass without any loved ones at their side or without any type of family involvement, but that is few and far between. And we know that, the other side of this process is the loved ones that this person leaves behind. So there are going to be needs to the patient and needs to the family. And this is probably why you guys know that I have an oncology background, but my heart is with hospice. And this is why, because it is really a privilege to, one, accompany someone on this journey. Okay. It is a phenomenal feeling to be able to bring joy to someone who may not have a lot of joy in their life because they are ending their life here on earth. And depending the circumstances around that, that might not be what they're ready for. They might not be dealing well with that. So if you can bring them some type of smile or some type of joy along that process, there is no better feeling than that, in my opinion. And I absolutely love working with these families, giving these families extra time with our loved ones, really meeting their needs, getting to know them. It's a very, very rewarding experience, at least for me anyway. So if we look at the definition of death, the definition of death is the permanent disappearance of every vital sign. So what are our vital signs? So we know our blood pressure, our temperature, our respirations, our heart rate, everything, all of our vital signs, they completely disappear. There are other terms that you may hear in the clinical setting or in different settings that also define death. So there's brain death, somatic death, and molecular death. So when we think about brain death, that is actually the death of brain cells. In order to determine the death, brain death, we would have to have an EEG on a patient, and we would see what we consider a flat line, so no activity. We can also, a patient can also experience somatic death. So this would be determined by any absence of any cardiac or pulmonary functions at all whatsoever. So there is no breathing going on. There's no heart rate, anything like that. Then we can have a molecular death, which is going to be determined by what we call the cessation of any type of cellular function. So if you have a patient that has a very flat EEG and no cardiopulmonary functions, and they still have living cells that permit their organs to be transplanted, is this individual really dead since they possess living cells, which is what we would call molecular death? So, you may say yes, I may say no, somebody else may say yes, somebody else may say, I don't know. These are questions that are not very easy to answer. And these are some of the things that you may encounter in the clinical setting. One of the big things that you're going to hear at the end of life, or that you may hear just in taking care of a med-surg patient, is this palliative care. So usually if you say the word palliative care to a patient, they automatically think they're dying in a couple of weeks and they're going to hospice. That's what they say. Oh no, we don't want palliative care. Is my loved one dying? We don't want that. We're not ready to die. So it's really important that you educate yourself exactly about what palliative care is. So palliative care is the prevention, the relief, or the soothing of symptoms of disease or disorders without affecting a cure. So we're not curing any type of disease, okay? So we're not giving chemo, that would be a curative disease. When we think of end of life, we are going to be managing those symptoms, or we can also have palliative care for a patient who maybe was in a major motorcycle accident and they've spent some significant time in shock trauma, okay? And maybe because of all the surgeries and all the injuries they've had, they may be in an enormous amount of pain. So we need to have a visit from a palliative care team to come and aggressively treat the symptoms of their disease. So we're not actually treating the disease, we're managing the symptoms, okay? So I want you to think about that. So palliative care is not just for your patient who is actively dying. There are many oncology patients who are getting curative treatment that are candidates for palliative care, because the pain associated with cancer and the treatments that we give them can be so overwhelming that they require higher levels of pain medication and management than we can just give them in the clinical setting. So it's not just for hospice people. I mean, frequently we see it given in the hospice situation or during end of life times, but it's not just limited to that. So that's the important thing that I want you guys to understand, because you need to be able to educate your patients about that. So palliative care deals with the management of those symptoms for a disease in which we know there is no cure. It is not necessarily end of life. So if we look at this little exemplar here about Mr. Jones. So Mr. Jones is a 50-year-old patient who has diabetes. He's had it since he was 8 years old. She now presents with continuing neuropathic pain related to the progression of her disease. So if you remember back, we've talked a little bit about this. Neuropathy is that numbness, tingling, decreased sensation in those lower extremities, right? And we see this from diabetes. Because the blood glucose, the sugar content of the blood is so thick, and that it, creates this issues with the nerves. So we know that, the disease not necessarily can be cured, but the pain will continue because of the disease. So we can provide palliative care in attempts to manage the pain that the patient is experiencing. So this patient obviously is not terminally ill and can live for many, many years with her symptoms. So like we've been saying, all palliative care is not end of life, but end of life care is palliative. So when our patients are experiencing a terminal illness, we provide palliation to manage their symptoms and increase their quality of life. We want to make the best out of whatever time that they have left. And that means managing their symptoms so that they're comfortable. One of the most important things that you guys need to think about when you are dealing with patients who are dying, who are actively dying, who are diagnosed with terminal illnesses, in order for us to really give those patients the most effective care, we need to examine our feelings about the death process. Some of our feelings can be based on common misconceptions that are prevalent in our own society. They might be based on experiences that we've had in the past. So in order for us to really give that good care to our patients, we need to examine our own belief system, and then we need to look and eliminate any type of barriers that can prevent us from providing that good quality of life, end of life care. So many clinicians, nurses are very uncomfortable with dealing with death and dying, and that's okay. I've told you since day one, just 13 weeks ago, that there are going to be things that you do in nursing that you may not necessarily do, that you may not necessarily like. I'm sorry. So if you don't like dealing with this, maybe you won't work bedside because you don't ever want to take that chance, experiencing a patient that passes away. You definitely probably won't work in hospice because we know the end result of hospice is that every patient that usually goes into hospice, the end result is that they're going to pass away. So you're going to avoid those things because you know that it's not something that you're comfortable about. But there may be a time where you have to talk to patients. So, we know that if you don't like dealing with death and dying and you're uncomfortable about it, you're probably going to be reluctant to talk with patients about it. And you're not going to know what to say when they talk to you. So there are certain situations, obviously, that are harder than others when we think about end of life. It's always more difficult when we see patients that are dying that are our age or even younger, especially when we think about pediatric population. That's a really hard pill to swallow. Because it just doesn't seem fair, So again, examining our own attitudes. How do we feel about this? So if we have these barriers and we don't address them, then we're not going to be able to meet our patients' needs. Okay, so we have to really think about how we feel about these issues. So physicians and nurses, we have been educated to cure, right? Everything that we've been learning so far is to cure things and improve things. So even though there's unfortunately, sometimes what you'll see is that even though there's not a cure possible, that we still continue to actively treat these conditions. You're going to notice that. Usually it's because you see it, especially with your younger patients. So by younger patients, I mean, children up to probably 50 or 60 years old. If they have a terminal illness, they will try everything they can to give these patients as much of a life as they can because, our average lifespan now is what, in the 70s or 80s. So if you have a patient that's in their 50s and 60s, or if they're 2 or 3, you're going to be pretty aggressive with your treatment because you want to give them as much of a life as possible within their wishes, what they would like. So sometimes death can be viewed as a failure on part of medicine. So we see this when we have many attempts at treatment that don't work. We know that the treatment modality will not work and that the patient is terminally ill, yet we continue with efforts that we know will not be effective to appease the patient. And that can be hard for clinicians sometimes. And it's something that you have to keep in your mind. So I've caught myself actually at several times taking care of patients when I see family members doing things to patients that I know are going to harm them. For example, I remember taking care of this woman who was in her, I forget now, she was in her late 70s, early 80s, still, got around good for her age, still had all her faculties about her. She was completely alert and oriented. She had a very aggressive form of metastatic breast cancer. It was in her bones. It was everywhere. And her family did not want her to give up. They wanted more time with her. They wanted her to keep fighting. They wanted to do every medication, every treatment that came available to her. They wanted her to do it. And this patient was tired. She didn't want to do it anymore, but she didn't want to disappoint her family. And I remember coming in to work one morning, and at shift change, that woman had coded. She had died. And I remember all of us doing chest compressions on her, and her chest was just caving as we were doing it. The metastatic disease was so bad that we were, on a good day, if you're doing good CPR, you're breaking ribs. That's what they say. Every bone in her was just crushing and breaking. It was just horrible. So because I see that side sometimes, and the patients don't, and they don't understand that, I feel like I say to myself in my mind, why is this family doing that? Why are they prolonging this woman's life? Why are they being so cruel to her? These are things that I've thought to myself sometimes. But then I have to quickly remind myself that this is somebody's loved one. This is somebody's mom. This is somebody's dad. This could be somebody's sister, somebody's brother, somebody's daughter, somebody's son. These people don't see this every day. Death is not normal for them like it is me. And they love these people, and they want to spend as much time as they can with them. So it's really important that we try and put ourselves in their shoes and really try and see things from their perspective, because their perspective is important. It is our job ultimately to give them all the information that they need to make a decision about their loved ones and about themselves. But we also have to remember what it's like to be that loved one and not be that nurse, because for them, they don't see death every day, and they don't lose their loved ones every day. So I just want you guys to remember that it's really important to think of it from the patient's perspective. Let's see. So a lot of some patient caregiver misconceptions. So you may hear, if I stop treatment, they will do nothing for me. Patients may feel that if they admit that they have a terminal illness, and the medical community won't do anything for them, and they're going to let them die. What we offer for them is relief from pain and suffering. So, that's not really true. If they decide to stop treatment, of course, we're going to do things for them. We're aggressively going to do things for them. We are going to make the most of the time that they have. We're going to find out what's important for them, what they want, and we're going to make them comfortable. We're going to make them, enjoy those last days and find out what's important for them. So we can offer them relief from pain and suffering. Some people may say, do I have to stop taking all my medicines? Is that it? Do I give up? No, you're going to continue to take your medications. We may choose to discontinue some of your medications, if they're therapeutically not working anymore and they don't make any sense. But so for instance, if you have a patient who is actively dying and he's only going to be, the doctors say, maybe you're only going to live for 6 more weeks. Is it necessary for them to take their anti-cholesterol medication? Probably not, right? Because in 6 more weeks, they're probably not going to be here anymore. We're not really so worried about that cholesterol level anymore. It's not something that's going to cause them to pass away any sooner. So that's just an example. Some patients say, is dying going to be painful? There's a lot of unknowns, right? Nobody's ever died before. They're only doing it for the first time. So fear of the unknown. What's it going to be like? What's going to happen? Where am I going to be? Who's going to be with me? Is it going to hurt? These are a lot of questions. So what you want to tell your patients is that there are so many different modalities that we can do to help ease their pain and keep them comfortable so that they don't ever have to suffer. If someone does pass away and they die in pain, it's because of our failure in adequately managing it. So, we're going to talk to you about some things that you can recognize and how we can treat some of the common things. But I think a really important thing is to remember that we can keep them comfortable, and that should always be our goal. So again, managing those symptoms is going to depend on how adequate of an assessment we're doing, what our experience is, and the dosing of the medications that we give. So if you were diagnosed with a terminal disease, or you had a major trauma where you are expected to die, what would you want done for you? Uncomfortable conversations, right? People don't like to think about this. People will say, I'm not talking about this because if I do, it's going to make it happen. I don't want to think about this. So when I say, what would you want done for you? What I mean is, would you want to be resuscitated? So if you die, do you want someone to do CPR to bring you back? Do you want to be intubated, which means mechanically ventilated, to keep you breathing, to keep your heart pumping? Do you want to have feeding tubes inserted to keep you getting nutrition? So you may answer that different than I may, that another person may, that sits next to you in class may answer, that your own loved ones may answer differently. So when we talk about these discussions and what people want to be done, we think of advanced directives. So advanced directives become very important. You guys need to know this, okay? So advanced directives are written documents that clearly outline a patient's end-of-life wishes. Okay, so advanced directives are kind of like the umbrella term. Underneath advanced directives, we have two things. We have what we call a living will, and then we have a durable power of attorney. So when we think of a living will, some people may misinterpret that a living will to mean that nothing more will be done for you. Okay, that does not mean that you will not receive any treatment at all. It's only going to describe what will be done if you have a condition that is terminal. Okay, so if you know that you're terminal, do you want aggressive measures such as CPR? Do you want to be intubated? Do you want to be on tube feedings? Some people say, I don't want a living will because if I'm in an accident, I want everything done for you. So having a living will does not prevent treatment. It only describes what you want to have done in the event that you have a very terminal condition. So some people may say, well, I have metastatic breast cancer. I'm going to die in the next 6 weeks. If I'm in the hospital and I die and someone comes in and finds me, I don't want CPR. I don't want to be hooked up to, I don't want to be intubated. I don't want to be on mechanical ventilation and tube feedings. If my life is not, if things don't look good and there's not a likelihood that I can recover from that. And again, this is everybody's personal decision, whatever they decide is good for them. So this is going to describe in very clear detail what this patient wants. Yes, I want CPR, but no, I don't want to be intubated. Yes, I want CPR, but I don't want to have any type of nutritional supplementation. So patients get to choose exactly what they want. So that is the living will. Then another terminology that we're going to talk about under that advanced directive is that durable power of attorney. So the durable power of attorney is that person that you as the patient are going to select to fulfill those obligations of the living will. So you establish your wishes through that living will, and then the durable power of attorney can make decisions on your behalf. So this needs to be a person that really understands you and that is going to respect your wishes. So you've told them, look, this is what I want. I don't want any CPR. Or yes, I want you to do CPR, but if you can't get me back, do not intubate me. Do not put me on mechanical ventilation and do not give me any type of tube feedings, okay? This is the person that's going to make that decision for you if you cannot. So your living will and your durable power of attorney, you guys need to know those definitions and how they differ from each other. The goal of end-of-life care, obviously, is we want to facilitate that process of death with dignity, okay, with our patients. So death with dignity. Dignity can be subjective, okay? It can be very different from person to person. What we all define in a different way is going to be different. I may want to die without pain, while another person may want to experience pain. The important issue is, how does your patient define it? What is important to them? What do they want? Where do they want to die? Who do they want with them? Do they want to be in their home? Do they want to be in a hospice center? Others may choose, some people say, I have to be at home. I have to be around my loved ones. Other people say, no, I don't want to die in the house. I don't want to create those memories for my family. I want to die, in some type of a facility. So it's really important that we find out what those patients want. And sometimes it can be a little hard. So if you have a patient, who is saying that they don't want to see their family because they're afraid that they're going to cause their family members sadness, because this is obviously a difficult time for them. I just think it's always important for us to, whatever discussions we're having with them, we always want to make sure that we're clarifying our patients' values. We just want to make sure that we're really understanding what their needs are, and so that way we can implement them. So throughout dying, Dr. Kubler-Ross developed a framework for the stages of dying in 1969. So she was able to theorize that dying patients experience 5 stages throughout this process of dying. She says that they're not sequential, but however, patients go in and out of the stages often and very quickly. So the first stage is going to be denial. So they act as if nothing has happened. They may refuse to believe or understand, and they can serve as kind of like a shock absorber. So, they just don't believe it. I can't believe this is happening to me. It really hasn't sank in yet that they have this terminal diagnosis or they're dealing with this terminal illness. After the denial comes anger. And you guys need to know these 5 stages. Anger is going to be where they're going to resist the loss, and they may or may not strike out at everyone and everything. Often their family members, obviously, and healthcare professionals can be the object of that anger, that displaced anger, because we're the closest to the patients. So first is that denial. And then when it sets in and they realize it's real, they can become very angry. Maybe that 37-year-old that has 2 kids at home, I just don't think that this is very fair. I haven't lived my life. I haven't seen my children grow. Why is this happening to me? This isn't fair. Why me? So that anger. Then they progress on to this bargaining. So they kind of move out of that anger and they try to negotiate, right? To maybe postpone things a little bit. So an example of bargaining would be having that mom say, yes, I am dying, and I understand that, but if I could only just live to see my daughter's graduation, that's all I want to do. I just want to see my daughter graduate, or my daughter's engaged and I just want to live long enough to see my daughter get married or to see my grandchild be born. So we've gone through the denial, we've gone through the anger where we're mad, and now we're bargaining it. Yes, we accept it, but now we just want to get to a certain point before it happens. And then after that, we can see this depression. So this can or may not be accompanied by feelings of loneliness. The patient may withdraw. We usually do see that the patient can have a silent depression where they don't verbalize their feelings very easy. Some things that we can do for these patients, sit quietly with them, sit at their bedside, listen to them, encourage them to discuss their feelings, let them know that you're there to listen for them, listen with them, hold their hand, all those good empathetic things. Oops, sorry. Acceptance. This is the individual will accept the loss and they begin to look to the future. So they find some sense of peace. Okay, they're finally at peace with this. They no longer have that internal struggle. It doesn't mean that they're ecstatic about the fact that they're going to die, but they're resolved about the reality of the situation. Okay, so what can nurses do to assist our patients during these stages? So when patients are experiencing denial, we can, this denial is the use of those defensive mechanisms to help cushion that patient's reaction. So the nurse should be able to understand that that they're using these defensive mechanisms in stage. We should recognize that this is a very common, this is that first stage. But the nurse should also be ready to have conversations with these patients if they need to talk. We don't need to remind the patient or bring up dying unless the patient initiates the conversation, okay? So if the patient would say to you, am I dying? Then obviously we would want to respond honestly. When we talk about anger, the nurse really needs to understand that the anger is in relationship to the dying process. It's not anger towards me. It's not anger towards the doctor. It's not anger towards the family member. It's in relation and directed towards this process of this, relationship to dying. We should also educate the family because they are also often the victim of the anger and they may feel that everything that they do is wrong. So family members are going to need a lot of support. When we get to that bargaining, we need to be very active listeners. So usually what we'll see is that these patients, when they do bargain, it's between God and the patient, and it might not be expressed. This creates the patient to have somewhat of a will to live, which sometimes can be very effective in increasing the patient's lifespan. When we think about the depression stage, we really want to offer ourselves to the patient. We want to be present with them, actively listen, right? Sit at their bedside, hold their hand, encourage their feelings, encourage them to speak their feelings. And then acceptance is that offering of self. So the nurse, again, these two stages, depression and acceptance, we just want to offer ourselves, our presence, and listen to them actively. So now what we're going to do is we're going to take a look at caring for the end-of-life patient in relation to that nursing process, right? We're always doing everything with relation to nursing process. So when we first start our nursing process, the first thing we're going to do is assessment, right? That's our A. So we're going to look at possible symptoms that the patient may experience at the end of the life. We're going to do it by each system. So we will also then be able to create our plan to help deal with each issue that can occur. So one of the things that we see that affects our neurological system, we can see that the patient can experience confusion, okay, for a variety of different reasons. They may be confused. They may suffer from something called delirium. Delirium can be described as being disoriented to time and place. They may have a very labile mood. They may engage in meaningless chatter. So they may just be saying things that really don't make any sense or that don't seem appropriate for the setting. And they can become very, very restless. That's all the delirium. That's all the things you would see during delirium. And then we also see lethargy, where they're not really coherent and they're not really moving around very much. When we look at the cardiovascular system, what are we going to see? We're going to see decreased activity levels. So they're not going to be able to tolerate doing what they were able to do before. We're going to see tachycardia. We're going to see that lowering blood pressure. We're going to see decreased peripheral pulses. Obviously, right? We have a lower blood pressure. Our blood pressure is our circulating blood volume. If that lowers, those peripheral pulses are going to decrease, right? Because the blood's not getting to the periphery. If that blood's not getting to the periphery, we're also going to have our extremities are going to be cold to touch. So that's why I always tell you guys, I want you to have a firm understanding of how everything works in the body. And if you understand what's going on pathophysiologically, you can identify what type of assessment things you would be able to see based upon what's going on in the body. So when we think about the gastrointestinal system, we're going to see anorexia. So really not having an appetite, not eating. We can see nausea and vomiting, constipation, and incontinence, again, for a variety of reasons. Decreased motility in our GI system can cause that constipation, incontinence if we're not coherent anymore and we can't hold our bowels, our urine or our stool. When we look at our Junatura in our system, so we're going to see a decreased urinary output as things come to an end, and then also incontinence. Integumentary, so these patients may not be moving around like they need to be in the bed. So there's a risk of them developing pressure ulcers, dry skin, and then cold extremities. When we think about spirituality, we want to really talk to our patients and we want to find out what their belief system is, if they have one. What do they believe in? What's important to them? Talk with family members, talk with them. We want to, it'll help explain a lot about some of the things that our patients are experiencing and the way that they look at things. So whether or not they have hope, someone who's very spiritual may have hope, where if someone who's not very spiritual, they don't believe anything, they don't really have a lot of faith or they don't believe in God or any type of higher power, they may be experiencing a lot of hopelessness. So our next process in our nursing, next thing we're going to talk about in our nursing process is going to be planning. So when we're planning care for these patients, the care that we plan is going to be in collaboration, remember, with the patient and the caregiver, which can be family members. We are going to be responsible for creating a plan to prevent or manage the presenting symptoms. So we know that as patients progress throughout their final stages of life, and we see that change in the vital signs, we know that we cannot prevent the lowering of the blood pressure. We cannot prevent the decreased motility, things like that. So what we have to do is we have to manage the symptoms that we see because of what we're seeing. Okay. So we're not preventing it. We're not stopping it from happening. We're managing the patient's symptoms. Okay. And we're going to do this in collaboration with the patient and the caregivers. So when we are planning treatment for that neurological issues that we saw, so the confusion and the delirium, what do we want to do to help comfort these patients? What things can we plan? What interventions? So one of the things that we see that can cause delirium during end of life is when patients have a full bladder, okay, and maybe they can't go on their own, maybe they have retention or something like that. We could put in a catheter. So some people may say, hey, that's a pretty invasive procedure. Why would we want to do that? Well, if the patient can't empty their own bladder and they're retaining for some reason and it's causing them agitation, we would use that for end of life. Because why? It's going to keep the patient comfortable, right? It's going to, if it helps to empty their bladder and it resolves their symptoms and they're not restless anymore and they're able to get some sleep, then we can use that as a comfort measure. We want to always make sure that we maintain a safe environment. So if our patients are confused, right, they're not alert and oriented, they don't know where they are, they may try to get out of bed, they may try to pull their catheter out, they may try and do something to hurt themselves. So we always want to make sure that we're maintaining a safe environment, right? So keeping the bed alarms on, things like that. We want to encourage family involvement as much as possible. We want their loved ones, for a variety of reasons, to be close to them and be around them. And we would encourage them to sit with the patient and also help keep them safe so that they don't get up out of bed and they don't do anything to hurt themselves. We want to make sure that we're reorienting them as appropriate. So if you go in and Mrs. Jones is saying, I need to go to the kitchen, can you hand me my, sweater over there on my rocking chair? Reorient her. Mrs. Smith, we're not at your home right now. We're at GBMC Hospital. We're in your room. Your loved ones are with you. So reorient them as much as possible. If patients are really struggling and they're really disoriented and they are at a high risk for hurting themselves, we can give them medications that will help control them, help limit that confusion and that delirium, and help them rest. So we can give them a medicine called Haldol, or we can give them a medicine called Adivan. So we can give these medications PO or sublingual. Sometimes if patients are in the hospital setting, they will get the Adivan through IV, okay, which usually in hospice and at home, patients and family members don't have access to that, and they don't always have a line, an IV line, because that can be considered a little invasive. So if they're in the hospital and they have an IV line, you could do it IV. In hospice or at a patient's home, it's going to be given PO or sublingual. And then it's going to help with that terminal agitation that they have. So a little bit more about the Adivan. So Adivan, the other name is lorazepam. This medication is an anti-anxiety agent, and it's a benzodiazepine. So it works in the body to depress the central nervous system. And how it does that is it enhances the action of GABA. You guys have been talking about this in pharmacology, so you know that GABA is an inhibitory neurotransmitter within the central nervous system. The normal dose that we see ordered is 1 to 3 milligrams. You can get 1 to 3 milligrams twice a day or 3 times a day. We can give it PO. We can give it IM, intramuscularly, SL, sublingually, or IV. It has a high half-life, so it works for about 10 to 20 hours. What are some of the side effects that we see? It can cause our patients to become dizzy. It can cause them to be very drowsy, very lethargic. In some patients, it can cause the opposite. It can cause them to be excited. And then we know it's a benzodiazepine, so it can cause respiratory depression. So things that the nurse would want to think about, obviously, we've given the patient this type of medication that can cause dizziness, that can cause drowsiness and lethargy. We want to make sure that we're implementing those things to keep them from hurting themselves. So if they normally had privileges where they could stand up and walk around the room on their own, they weren't a high fall risk. They are now because we've given them this medication. So we want to make sure we're keeping them safe. And we want to use cautiously in patients who have severe renal impairments because it's hard on the kidneys. Okay, another medication that we said that we could give is Haldol, which is also called Haloperidol. This medication, the classification is an antipsychotic, a neuroleptic, and a non-phenothiazine. So what does Haldol do? It alters the effects of dopamine in our system by blocking the dopamine receptors in our central nervous system, which will then decrease any agitation and any psychosis. The half-life of the medication is going to be 15 to 35 hours. Side effects that we may see in our patients is blurred vision, dry mouth, tachycardia, extrapyramidal symptoms. So that's going to be that mask-like face, tremors, rigidity, tardive dyskinesia, and constipation. You guys just learned about that in pharmacology, so you guys should remember that. Nursing implications. So what do we as nurses want to think about? It can cause hypotension with other antihypertensives. It can interfere with nitrates, and alcohol can increase its effects. So we want to make sure that we monitor, keep them safe, assess bowel function, and we want to assess their mental status. And the normal dose that we give is 0.5 to 5 milligrams twice a day or 3 times a day, either PO, IM, intramuscularly, or IV, intravenously. Another issue that we talked about with patients regarding their respiratory system was dyspnea. So the first thing we want to think about is what's causing them to be shortness. What is causing them to be short of breath, right? That's the first thing we want to look at. If the patient has some type of chronic obstructive lung disease, we could use steroids for them to help increase their, to help decrease their work of breathing, increase the oxygen, or we can use bronchodilators. They can be effective. We can also use oxygen for comfort, okay? Make it easier for them to breathe. We can give low doses of morphine. So some things you will see frequently when patients are going through the process of dying, that they will breathe very shallow and their respirations can be very high and they can have a lot of shortness of breath. So morphine is one of the medicines that we give them all the time to help decrease their work of breathing, because sometimes it can look so uncomfortable that it's very upsetting to the family members how quickly they're breathing or how short of breath they are. And of course, we don't want the patient to be uncomfortable. So we would give them a low 1-2 milligrams of morphine. We know those bronchodilators are going to work to decrease that airway resistance, right? And then increase the amount of air they can get in. We can position them to help increase the, make their work of breathing better. So putting them in a higher position, right? We can space activities if they're still really alert and oriented and they're moving around, space the activities that they're doing to help them from getting so fatigued so quickly. And then make sure that we're keeping them in a comfortable position that's comfortable for them. For cardiovascular, again, we want, just like with the dyspnea, we want to space our activities out to prevent the patient from getting very fatigued. We want to treat symptoms that are causing discomfort, and then oxygen to decrease the cardiac workload of the heart. So we said that we can use oxygen for comfort, and we can also use it to make the heart work more efficiently and decrease the workload. For gastrointestinal, we want to be able to treat any uncomfortable symptoms that they're having. So are they nauseated? Are they constipated? Giving them something to help them go to the bathroom, giving them some type of a medicine to control their nausea. Diets are not important. So one of the things that we see, and we're going to talk a little bit about this in a couple more slides when we talk about symptoms, when loved ones are sick, what do we always want to do? Feed them. Here, have some water. Here, have something to drink. Here, eat this, do this. You need this. When someone's terminally dying, sometimes these things can make things worse, food and water. So it's not really our first go-to is to make sure that they're eating or make sure that they're drinking. If they want to eat, give them whatever they want to eat. If they want a cheesesteak, if they want ice cream and milkshakes, let them have whatever they desire. Smaller portions can be helpful because remember we said, they lose their peristalsis decreases, they can become nauseated, they can become constipated. So we don't want them to throw up. So we do encourage smaller portions so that they don't get as overwhelmed by the meals. With GU, we want to make sure that we're providing excellent skincare, especially if the patient has a Foley. If they're incontinent, we want to make sure that we're keeping them dry, taking care of their skin, cleaning it really well, putting a moisture barrier down there so their skin doesn't break down. Integumentary, we want to make sure that if the patient's not moving themselves, that we turn them every 2 hours, okay? We don't want any type of skin breakdown. We want to make sure that their skin is excellently cared for, no redness, no bruising, no skin breakdown anywhere. We want to change their linens every day, just like we normally would. And then as they can tolerate it, we want to make sure that they get out of bed. One of the things that we really need should be in the forefront of all the care that we give is that the patient is in control. We need to do things according to, what the patient says. What are their values? What are their beliefs? What's important to them? And then we also want to help educate our patients about, instruct the family members on what they can do to assist in their patient's care. So once we find out what those important things are and we come up with some good interventions, we need to include the family member so they can provide that care at home. We did say a couple slides back that, food is often a focus of everything that we do, especially when we're sick. Food. So we do have to recognize that. Some patients that have an appetite, we want to give them whatever it is they want to eat. And if the the family members want to bring things in, we want to encourage that, okay? But we do need to educate our family members that it's not going to be, a necessity. If the patient doesn't want to eat it, we don't have to force them to eat it. We don't have to make them eat because their appetite does decrease and it can make them nauseated or constipated. All right, so this is important. I want you guys to know this. When we think about hydration at the end of life, so we've talked a little bit about how, food is not always necessary. So as our body starts to progress through the end stages of life, we do see that the body is not able to manage fluid like it used to. And it kind of makes sense, right? Because everything is slowing down. Nothing's really working as efficiently as it used to. So what we can see is when patients have when they have a lot of fluid intake, or if we're giving them fluids, they can experience what is called either congestive heart failure, right, which is fluid all around the heart, or a wet death. So wet deaths can be very, very uncomfortable for patients. There's a lot of secretions. And when patients get to a certain point at the end of life, they can't get those secretions up. So it's not real comfortable. So a dry death is going to be more comfortable for patients. So when you have that family member who wants to just give them something to drink at every chance they can, that might be a conversation that you want to have with them, that it can cause the family member more harm than good. Patients eating at the end of life, when they stop eating, it's because the body is unable to manage the food anymore. And when we keep feeding them, it's going to cause nausea and distension, which is not comfortable. So assisted suicide. So this is a pretty hot topic. I'm assuming that most of you have heard about this. Maybe you have not. This is where a nurse or a healthcare provider assists a patient with dying with dignity. And not all states do this. Some states, it used to just be one state. I believe it was Oregon, but I know that there are other states that now do this. Maryland is not a state that does that. The ANA, the American Nurses Association, has put out a statement that any nurse who participates in assisted suicide are in violation of the Code of Nurses, the Code for Nurses. So that nurses should support effective symptom management and not aid in assisted suicide. Pain management, when we want to control their pain, usually we can just give them, if we're giving them morphine for their breathing, there's a lot of different medicines we can give them, Dilaudid, sometimes Motrin if that's what helps them, Tylenol, morphine. We're going to, in some of your future lectures, we're going to talk a little bit more about that. Dyspnea, again, we're going to look for those underlying causes, use steroids or bronchodilators if we need to be, give them oxygen for comfort, make sure we're positioning them comfortably. So anorexia, so we see that this is something that's going to be normal as disease progresses. We do need to make sure that we talk to our families about that, right? And if the patient is still willing to eat, we want to make sure that they're having smaller portions. But then we want to tell them when they do have the desire not to eat anymore, that we don't force them, because we can cause them to have symptoms that are pretty uncomfortable, like the nausea and the distension. Remember, we talked about the delirium. They may have a full bladder, okay? If they have that, we may give them a Foley, right, to help facilitate that output of urine to decrease the symptoms that the patient's having. We might see terminal agitation. So this is just where they're saying things that don't make any sense. They're very agitated. They're trying to get up. They're very restless, uncomfortable. They may be screaming. They may be crying. We can give the Haldol or the Adivan, right? We can give it buccally, PO, or sublingual, IM, IV. Oops, lost my place here. All right, so remember when we talked a couple slides back about when we give our patients fluids and it can increase their secretions, right? And it can cause them to have a wet death. So they can develop something called a death rattle. So this is when the patients have all of this mucus and all of these secretions that are just laying right in here in the chest and up in the upper airway, and they can't move those secretions. Probably because they're not really coherent anymore, and they're not talking, they're not really coughing anymore, they're not able to move them. We also see that it happens in combination with relaxation of the bronchus. So these secretions get stuck there, and eventually it can cause the patients to stop breathing because they kind of, suffocate on their own secretions. So one of the medicines that we can give sublingually is Levsin, that will help decrease the secretions in the patients and make them more comfortable. So what are some symptoms that we would see when our patients when death is imminent and when they're close to dying? Because patients, family members will say, how do you know? When's it going to happen? Is he close? Is it going to be today? They're always wondering when this is going to happen. So one of the things that we see are those Cheyne-Stokes respirations. So you remember they're kind of cyclic. They have periods of fast breathing, shallow breathing, and then apnea, right? We think that the patient stops breathing. They may have a cessation in their breathing for 10 to 20, 30 seconds, and then all of a sudden they breathe again. We do see that they have a loss of consciousness. So if they were previously talking with you before getting up out of bed, conversing, they're no longer doing that. They're pretty much just laying in the bed, not really moving. We do always encourage patients' family members to continue to talk to them, because they do say that hearing is the last thing to go. So even if they're not conversing with you, encourage family members to keep talking to them until they're no longer with us. Dyspnea, shortness of breath, is something that we see, shallow breathing, but we do still see that continued need for pain medications to keep them comfortable and keep them from being agitated. So one of the things that we're going to focus our nursing care on for these patients is to position them for comfort. We want them to have a proper body alignment, maybe not necessarily high Fowlers, because that isn't comfortable. We definitely want to have them in a position high enough to help the oxygen get into the body. We want to do mouth care very frequently, at least every 4 hours, if not sooner, depending on what kind of secretions they have. Make sure we're taking care of them if they're incontinent, changing them frequently, doing good skin care, cleaning them up, putting moisture barrier on so they don't get any skin breakdown, repositioning them every 2 hours so that they don't have any skin breakdown, oxygen for comfort if they need it. And we can also give them cool cloths on their head, on their chest, wherever they like it for comfort. So we did say that one of the medicines that we could give to help decrease those secretions in our patients, is Levsin, also called hyoscyamine. So it can also be a patch sometimes. So this type of medicine, Levsin, is an antispasmodic, and it's also an anticholinergic. And I know you guys know what an anticholinergic is because you guys just learned about it. So how does it work? It inhibits acetylcholine in our smooth muscles. So then it decreases the secretions in our GI tract. What is a normal dose? Usually 0.125 to 0.25. We can get it 3 times a day or 4 times a day, PO, IM, IV, subcutaneous, and sublingual. Sometimes they can put a patch on the back of the ear, which will help that as well. The half-life is 3.5 hours. Side effects are dry mouth, nausea. It's an anticholinergic, right? So dry mouth, nausea, urinary retention, blurred vision, confusion, dizziness, drowsiness. So we're going to make sure that when we give this to our patient, we're monitoring that urinary output. We're going to assess their mentation. Are they alert and oriented? Are they developing confusion or dizziness? If we give them too much of the medication, there is an antidote called physostigmine. We would want to make sure that we would take safety precautions in our patients, keep them from falling or hurting themselves. Male patients with that take this medicine with BPH may have urinary retention, or they may have trouble starting a stream. So what different care settings do we see for patients that are experiencing end of life from like some type of terminal illness? We can see in-home hospice, where they die in their home with their family members. We can see inpatient hospice in a facility, or we can see, and sometimes inpatient hospice can also be in a hospital, or we could see an assisted living specific for hospice. So when we think about mourning, we think, there's a lot of stages to, well, not a lot, but 4 different phases that someone goes through when they're mourning. So the first phase is going to be numbing. So they feel kind of stunned. It might not seem real to them. They're having a hard time, grasping it. They don't really know what to feel. They don't have any type of feeling. The next is going to be yearning and searching. So these can include emotional outbursts of just uncontrollable sobbing. They have to experience the pain of grief. Some people, they have to experience that pain, or anything that allows the person to avoid or suppress experiencing that is going to delay the grieving. So this is something that people have to experience. If they don't experience that pain, they're never going to be able to get through these stages. Then comes disorganization and despair. So they will endlessly examine how and why the loss occurred, and then the examination eventually gives way to acceptance of why it happened. And then reorganization. This is the last stage. So it begins to accept, they begin to accept the unaccustomed roles, because now things have changed, right? So if you had a wife or a husband who was caring for their loved one, their partner, and now it encompassed all of their days, right? They had this medical illness for a couple of years, and then you had home hospice, and they spent all this time caring for this person. Now, all of a sudden, once they're gone, they have this big letdown. All of a sudden, they're not busy all the time. They don't have things to take up their time. They have more time to think. So through this period of reorganization, they begin to accept their new role. They may acquire new skills and then go on to build various new relationships. They have to accept the reality of loss. They're going to have to work through that pain or grief. How long that takes or what that looks like can be individual for each person. They're going to adjust to that environment without the deceased. Again, how long is that going to take? What is that going to look like? It's going to be different for each person. And then they're going to be emotionally, they're going to relocate at some point and move on with their life, because we do know that whether we want it to or not, the world keeps turning. So what does grief look like? What does it feel like? What do people say how do they describe it? Some people say that it's a hollowness. They just feel very empty. Some people describe it as a tightness in their chest. Some people become very oversensitive, so to a lot of stimulation or to noise. Some people experience sleep disturbances, appetite disturbances. They may have absent-minded behavior. They may forget things, not remember to do certain things. They may have a sense of presence of the deceased. They may say that they feel them or they feel like they're there with them. They may have a yearning to see them again, to be with them again. They may experience fatigue or anxiety. They can experience all of these, one of these, two of these, five of these. It's really an individual process for each person. And then we want to think about rituals. So when we talk about rituals, so what is going to happen with these patients? Again, and this is going to be their culture and their beliefs are going to determine or define any rituals that they have. So is there going to be a viewing for their patient? Is there going to be a viewing where families can come between a designated time at a funeral home where family members can come visit him? Are they going to have a funeral? Are they going to, clean out the loved one's home and invite people over? What does it look like? What are their rituals? So again, this can be very different depending on the family member and what their cultural preferences are. So once our patient has passed and they are no longer with us, it is a job of healthcare professionals, nurses and techs to provide what we call post-mortem care. So we would provide care to the patient as needed. So if they had a lot of secretions and they had things coming from their mouth, we would want to clean up their mouth. We would want to, if they were incontinent of urine and stool, we would want to make sure that we cleaned them up. We would want to clean their linens, right? Lower the lighting in the room, lower the head of the bed. If the patients had any dentures, we would want to put the dentures in. So thinking of these things, these are things that we would want to do if we would want to do it if the patient passed away, but like with cleaning the linens and things like that, we might not do that if there's no family members there. So if family's coming to see the patient, say the patient died at 3 a.m. unexpectedly and there was no family members there, we would want to make sure that we cleaned the patient up as best as possible so that it wasn't, so that the patient so that the family members didn't have to be any more overwhelmed when they already are, when they see their loved one is no longer with them. So we want to make sure that they're clean and tidy, comb their hair. We want to clean their face and make sure we do good mouth care. We want to make sure that they have good, clean linens on the bed and new covers to cover them up and lower the lighting, lower the head of the bed. If they have dentures, put them in. Close their eyes by applying pressure for a few minutes to the eyes. So if you just try to close them, depending on how long it's been, they may not go. So you really do have to apply pressure for a couple minutes to keep the eyes closed. Remove all tubes unless scheduled for an autopsy. Okay, so if there's going to be an autopsy, you would not want to remove any tubes. And then offer the family time to visit. And again, that's going to be different depending on how many people are coming, where are they coming from. Ideally, we try and say a 4-hour time limit because unfortunately, you do have to put some people would stay for days if you would let them. And we know that that's not healthy and we know that that can't happen. So, ideally, we like to say 4 hours, but hey, if someone's coming in from out of town and it's going to go a little over that time and, we know how important it is for someone to be able to see their loved one after they've passed. So we do try to make concessions for that and accommodate all the family in that circumstance. Okay. Morgue care would be according to whatever your policy is. When we talk about a morgue kit, we would, and again, it's going to be really different in each facility. In my facility, we would put them in what they call a body bag, a mortuary bag. We put a toe tag on the patient, and then we put the other half of the tag on the outside of the container. We do keep their legs and their arms closed. We put their arms on top of each other, and then we would take them to the morgue at the hospital. Usually you have a morgue cart, which is designed just to take a patient that's passed away, and it has a specific cover that goes over top of it so that people can't see that there's a body going down in a bag going down the hallway, because obviously that can be very upsetting for just anyone who hasn't lost a loved one if they see that, and especially if their family member were to see that. And then documentation. Documentation is actually a huge piece of this. So you would document the absence when you would want someone to come and pronounce when the patient passed away. So usually the doctors are not there when it happens. So what happens is if you walk in and your patient isn't breathing anymore, or you think they've passed, you take your stethoscope, you listen to them, you note the time. If there's no respirations, no heartbeat, you call the doctor and let them know. And then they usually will say, what time did you notice that they weren't here? And then that's the time that the doctor puts on the paperwork. So you would want to document that. You also would call Living Legacy. So Living Legacy will get in contact with the patients if the patient is with the family members, if the patient is a candidate to have any of their organs donated, okay, to patients who need transplants. But so you would call them, you would give them information about the patient, how old they were, what their past medical history was, what type of treatments they were undergoing, when the patient died, things like that. And then they would make a decision and they would contact the patients. It's not anything that we ever the patient's family members, it's not anything that we ever talk about with the family members. So this is an exemplar here. You guys can look over this and we can talk about it more in class when we meet next Tuesday, but that is lecture for week 13, end of life. If you have any questions, you can email me, and then we will talk more about this in person next Tuesday when we meet. Have a good night.